Hi, thank you for joining. My name is Sean Tatum Williams, and I am going to be your host of the Risk Adjustment Hour. It's the key to risk adjustment, and the key is to keep educating yourself. I want to thank you for joining me for season 1, episode 1 of the Key to Risk Adjustment. We're going to jump right in. These will be 30-minute segments specifically geared towards the physician, the working physician in their office who have Medicare Advantage patients or those Medicaid patients that are a part of the HHS model, or those patients that are a part of the ACA or the Accountable Care Act who've bought their insurance on the healthcare exchange. 25% of those customers or patients for my providers also fall into a risk adjustment platform. So, what is risk adjustment, you ask? Well, I'm glad you asked because I've got an answer for you. So, risk adjustment has been around since 2001 and 2004. They started to get more formality with risk adjustment. Now, it was created to estimate future expenditures for Medicare beneficiaries. So, it was initially employed by CMS to adjust capitation payments for Medicare Advantage plans. But now it's used by multiple MAOs or Medicare Advantage organizations, as well as health plans. And this is a way that they're able to have predictive analytics of their patients or their beneficiaries, right? So being able to predict what their cost, their medical health care cost is going to be in the predictive year. So we're going to jump into that a little bit more because I want to make sure that you understand the basis of our conversation, and I want to get your questions. I want you logging in. Hit me up on Instagram at MedCenter Billing and Coding or at MedCenter Coding Institute. We're ready to take your calls. You can DM me and you can certainly email me direct at ctatum@medcenterbilling.com. Again, that's ctatum@medcenterbilling.com with any questions about risk adjustment. With that, let's jump right into what we want to get into today. What is risk adjustment? So, within risk adjustment, one of the key things I wanted to point out here is in this model, not only does it look at your patients or those Medicare enrollees and beneficiaries, but it looks at how they became entitled to Medicare. So, were they an age in, which means were they 65 years old and aged into Medicare, and that's what made them eligible for Medicare, or were they disabled? Your disables could be anyone of any age, and these are going to be people who have a disability that has been deemed by CMS for them to be eligible for Medicare. So under that, you've got your aged in and you've got your disabled. Those are generally going to be your 1 or 2. You're also going to be looking at not only how they became entitled to Medicare in the risk adjustment model, but also what their age group is. So all the way from birth to 100 or greater, they're categorized in increments of 10 to 15 years. So you'll see that within the HCC model breakdown, and I'll share that model in some of my future podcasts and some links in my podcast of where you can go and find these models yourself. So first, again, we're starting with that patient demographics. How did they become entitled to Medicare to begin with? Did they age in or are they disabled? Then we look at what their income status is. Are they low income status, or you'll see the acronym LIS? And with those low income status patients, they tend to also qualify for Medicaid. And in this model, this Medicare risk adjustment model, those patients who qualify for Medicaid and Medicare are called dual eligible. So when you hear the term dual, or you're talking with some people who work in healthcare and work with managed care enrollees, you may hear dual membership. Now, what my providers always need to be focused on with those dual members, and this is a hint, a tip, Make sure you write this one down. This is, or I like to call it rather, let me go ahead and introduce this. This is what I like to call a Kodak moment. Say it, record it, say I said it, write it down, tell a friend, save it. These Kodak moments are those opportunities where you may take that tip and put it into action in your practice, in your day-to-day CDI or clinical documentation improvement. Now, again, those dual eligible members can switch health plan to health plan every 30 days. And that makes it hard for our providers to continue to manage them and manage their care effectively. So, we've talked about how they age in or how they become Medicare eligible. We've talked about their income status and whether they are traditional Medicare or whether they are dual eligible. And then you also have your Medicare Advantage. So, Medicare Advantage are health plans that many of them were traditionally commercial only. Some of them now have what's called a Medicare Advantage line of business. Many of you have heard of them. You've certainly seen the commercials. There's Cigna Medicare Advantage. There's Aetna, Humana, United. There's some local to Houston. You've got Community Choice, Devoted, Bright. And a lot of all these health plans have those Medicare enrollees, and they also have dual eligible members. Now, let's get back to the basis here. I've kind of got off there, but this is my passion. I love risk adjustment, and I love it when my providers and my students that attend my classes on risk adjustment, when they ask questions or when they have that aha moment, and they're able to take what I've are given to them as far as a teaching opportunity, and they're able to apply it to their day-to-day or into their opportunities for testing or exams that they may have. So again, getting back to this model, so it breaks down those patients who are, again, aged in or forgive me, excuse me, those that have aged in or those that are disabled, and then you have their low income status, and then adding to that, the part of the model is called the ESRD. And if you're not familiar with that acronym, it is end stage renal disease. So patients who have chronic kidney disease that has progressed to end stage renal fall into a totally different risk adjustment model. They are looked at separately because when you think about this risk adjustment model, I'd like to describe it as when you think about a diagnosis such as diabetes. So, diabetes in itself is a very managed diagnosis. Many of us have family members that have diabetes. Thank you all for joining. I see you all there saying hi. And but some of us have family members that their diabetes has progressed, and that diabetes has progressed to diabetes with chronic kidney disease or diabetes with ophthalmic manifestations. And so, in those instances, it is no longer a simple diabetes, and your providers are documenting oftentimes that it is diabetes with these complications, but ultimately, what ends up on the claim to the health plan or to CMS is only just that diabetes diagnosis. So, it's given a false diagnosis of what this patient actually is being treated and managed by our providers. So, in this model, they're looking at your patient demographics, how they became originally entitled to Medicare, what their income status is. They're looking at the diagnosis, and they're also looking at in this model, they're looking at the key factors of how those diagnoses, those chronic conditions, and some acute impact the outcome of care for the patient. So that brings the model together. So you've got enrollment or entitled to enrollment, you've then got their LIS, and then you've got whether or not they're in the ESRD model. And then the last part to this model, well, there's two other parts that we'll talk about today. One that I want to make sure that we don't forget is what's called the prescription prescriptive HCC. So some diagnoses within this risk adjustment model are the hierarchical condition categories, and we'll jump into that a little bit more in the rest of this call. In that is where the opportunity lies for those providers to document those chronic conditions that those patients may have, and also those prescriptions that are written for those diagnoses. Many of those prescriptions also carry a risk adjustment or fall into a risk adjustment category. And specifically, those are called prescriptive HCCs. And then, lastly, in the model, there is what's called a interactive diagnosis. So, an example of an interactive is some patients may have congestive heart failure, and they may also happen to have a behavioral health diagnosis like schizophrenia. And in the risk adjustment model, patients or Medicare enrollees who have congestive heart failure and schizophrenia, there is an additional risk adjustment weighting for those particular patients. Now, I'm going to pause there for a second. I'm going to check online and see if we have any questions. No questions just yet. Hey, Tiffany, how are you? Thank you for joining. Hey, I'm glad y'all joined. All right, so let's dig in here. So what I wanted to jump to is there's a little over 9,800 diagnosis or ICD-10 codes. That's International Classification of Disease. So those are when you go to the doctor and they say, okay, we've ran a test, we've swabbed your throat, and now we've determined that you have strep throat. So then there is an ICD-10 diagnosis for strep throat. And that diagnosis then goes on your claim to your health plan or your health plan carrier, and that's how they know the procedure code, which is a CPT code or current procedural terminology. Those are the procedure codes and services and or DME equipment, durable medical equipment such as crutches, wheelchairs, bandages, those type things are also listed within there. So again, on that bill, that diagnosis of strep would be considered from an ICD-10 code. Now, in the risk adjustment model, or the HCC model as it's called under the CMS model, CMS being Centers for Medicaid and Medicare. So we kind of combine those together, and I promise to make clear of all the acronyms that I use because I don't want to lose anyone. I want to keep you right here with me because, again, the key to risk adjustment is to keep educating yourself. I'm going to repeat that quite a bit. So, in the risk adjustment model, we've got well over 9,500 ICD-10 codes that impact how those patients are then evaluated at the level at the CMS or at CMS. So if one of those diagnoses for a Medicare enrollee should happen to fall into that HCC category, those 9,800 diagnoses, then they have what are called risk weighting. So the way that I've taught this in the past years to providers and staff and my students is to think about a person who has renal issues, right? So if you've got some diabetes and you may have diabetes with chronic kidney disease, then you may be seeing your provider on a quarterly basis and they're going to be running labs. They're going to be looking at what your EGFR is, right? What your level of your A1C is. They're wanting to make sure that you're in a managed area and that you're progressing and doing well on your medication. They may need to bring you in more often to adjust those medications for better outcomes. In Medicare Advantage, it is all about the outcome of the care for patients. Also, the patient experience is very important to CMS, and they send surveys out to their Medicare enrollees and ask them about that. That's another podcast. So stay tuned. I'm going to get real deep into this and make sure that you know what you need to know in order to be successful in risk adjustment. Now, with these 9,800 categories, they break down into 79 different what's called hierarchical category conditions. Man, I'm getting tongue tied. Let me have a sip of water. They put my water in this funny glass. I like it though. Now, with these hierarchical category conditions, there's 79 of them. So these 9,800 diagnoses break down into 79 categories. And those categories hierarch, kind of like the game of spades. Do I have any spades players on here tonight? Listen, I am not a spades player and I am the one who will renege. But when it comes to risk adjustment and trumping, I completely understand that. Let me see if I can explain it to you. Now, with the 79 categories, as one would think, you would think that each category would start with 1, 2, 3, 4, and so on and so forth. Well, as it may be, that is not exactly how the HCC categories break down. Some of them actually skip around, and in that sense, you always want to follow how they hierarch. So you may have diabetes, which may fall into, and let me just pull that up so we can look at it here. So we have, or let's talk about chronic kidney disease. I have a good sample here. So chronic kidney disease or acute renal failure, which is at the top of this HCC. It is in HCC category 35. So you've got acute renal failure. That is when your loved one or you are at the emergency room and you are in a life or death situation and your kidneys are failing. That is acute renal failure. It could progress to other things, but acute conditions are generally handled in an inpatient setting. Some are handled in outpatient, but most acute conditions are going to be in an inpatient setting. And by inpatient, I mean hospital setting, ER, facility, some of those type things. Now, when thinking about that, so again, follow me. With our acute renal failure is that HCC category 135. Followed immediately by chronic kidney disease stage 5. So stage 5 chronic kidney disease, if you're not familiar with chronic kidney disease, it stages from 1 to 5. And then after you've reached a certain GFR, the provider may review that Medicare enrollee's labs and they will look and say, hey, their labs are now have reached what's called ESRD. Remember that from earlier? That end-stage renal disease. And when patients reach end-stage renal disease, many of them are on dialysis. Some of them are on dialysis far before they reach ESRD. But in general, when you hear the term ESRD, you can generally bet that they're on hemodialysis or that they're on intraneal dialysis, but certainly there is some type of dialysis that is occurring, or they're on a transplant list. So again, you've got your acute renal failure, then you've got your chronic kidney disease stage 5, then you've got your chronic kidney disease stage 4. And stage 5 is HCC category 136, so acute 135. Then we're coming down from acute to stage 5 CKD. It's HCC category 136. And you see it's going up. HCC category 137 is CKD stage 4. And then HCC category 138 is going to be CKD stage 3. You have a CKD stage 3A and B now. So if you see the hierarchy here, you would think in how this works. If let's say I'm going to use me as an example. If I have chronic kidney disease stage 5, and I'm not following my doctor's orders, I'm not taking care of myself. I'm still drinking Dr. Pepper for morning, breakfast, lunch, dinner, and snack, and all the other goodies. And not to mention, I'm just doing some other things that are really damaging my kidneys. So now I've progressed, and I have appeared at the hospital because I'm in mad pain. And I get there to the hospital, and they run some exams, and my kidneys are failing. Now I'm in acute renal failure. So even though I've been going to my doctor for the last year and I've been holding with my EGFR and my labs have been at this certain level, so I've been able to maintain a stage 5. But now I'm presenting at the ER and I've got acute renal failure. That acute renal failure is going to hierarch that chronic kidney disease. So ultimately, what Medicare is going to acknowledge as the condition that I am inflicted with, or me as the enrollee that needs to be managed, is going to be that acute condition for that calendar year because it hierarched the chronic kidney disease stage 5. You with me? All right, great. Okay. So that is the hierarchy, and we're going to spend a lot more time explaining that in future podcasts and drilling into that and how it works and why it's important and why my providers even need to know about it. Now, as we continue to talk about this model, I wanted to bring out some very important things about the model that just really helps to remind providers. So, number one, CMS or Medicare, and CMS meaning Medicare and Medicaid, or Centers for Medicare and Medicaid, they look at this model every year as an opportunity to review where their cost expenditures are with their Medicare enrollees. So the health plans in which you contract with that have those Medicare enrollees are also submitting that information to CMS. So they're going to from time to time ask you for medical records, and it's going to be important that your staff understands how important it is to help gather those medical records for you and get them to the insurance plan. Some plans that you're contracted with will have EMRs that they can back in, log into, which is great for you and and your staff. It's less upset to your day to day. They can log in, pull the data that's needed, and submit it to CMS for validation purposes. So in this model, not only does CMS take those diagnoses that are submitted, those ICD-10 diagnoses that are submitted, and use that for predictive analytics for cost expenditures for the predictive year for patients, they take that, and for those diagnoses that aren't reported, those expenditures are not allowed. So that is one of the things that many of my providers struggle with, and that is why this podcast was created. There is a need for the independent physician and the physician who's working with the facility that may not have time to go to all of the trainings or to sit on a 2-hour call. I want to give you quick, to the point information that you can use. Keep educating yourself because that is the key to success with risk adjustment. So let's get back to it. Now, in Medicare Advantage, or in this world of Medicare Advantage where we're going to have a lot of the Medicare enrollees, I want to bring in what's called the HHS model. And in this is the Health and Human Services model. This is going to be those Medicare Advantage patients. Those Medicaid patients. So a little bit different. The model is a little bit different, and it looks at a lot more. Their diagnosis obviously are spreading more, not just for those that have aged into Medicare that are disabled, but also some of those children who are Medicaid eligible that are in the plans. They're looking at those immunizations. They're tracking certain chronic conditions that those patients may have. And again, we're now talking about pediatric as well as adult in that HHS model. So when thinking about that, There's certain risk adjustment attributes that you want to make sure that are in the diagnosis, or excuse me, in the documentation that's consistent. Providers want to show the continuity of care. They want to show whether or not the patient is improving or whether or not their condition is worsening. And then they want to know, how are you managing this? Okay. So when I talk to providers, dig in with me, come in close, come on in, come in. When I talk to providers about risk adjustment, I tell them that CMS wants you to be a helicopter parent. What's a helicopter parent, you say? A helicopter parent is a parent that hovers over the situation and they make sure that everything goes according to plan. How do I know? Because I was once a helicopter parent. Yes, when my youngest was in high school, I spent every day volunteering any free time that I had at the school. I had an ID badge. I worked at the cafeteria. I sold Chick-fil-A at lunch. I was there volunteering for numerous things, to the point that it was a little obsessive and I was diagnosed as a helicopter parent. True ICD-10 code. Look it up. Now, as a helicopter parent, you, the provider, you're hovering over the situation and you're making sure that everything goes according to plan. Meaning that if your Medicare enrollee needs to go and see a cardiologist or specialist, you're writing that referral. You're making sure that they get to that cardiologist, and when they go to that cardiologist, I like to refer to that cardiologist, and no disrespect to my specialists because they keep our patients well, but I like to refer to them as the substitute teacher. So you're that helicopter parent hovering over the situation, making sure everything is going according to plan. And that substitute teacher is going to see your enrollee, manage whatever specific care that you had for them, and then they're going to write a report and send it back to you. Now, I ask you, when you get a report at home from your substitute teacher, what do? Well, in my house, we used to bring home those letters that we had from the teacher or substitute. We'd sit at the table and we would review it together. And that's exactly what the primary care physician should be doing with their patients. Hovering over the situation, making sure everything went according to plan. So they went out, they saw the cardiologist. Okay, so I got the results back from the cardiologist. I have a report from the cardiologist. They said that they're now going to have you on a new medication and that they want to see you quarterly for a new EKG or a Doppler or those type things. So again, reviewing that medical record with that patient now has acknowledged to the patient, I'm managing your care. Not only did I suggest a provider for you to go to for cardiology, but I've also communicated with that provider, one, how I'm managing your care, and I've communicated with them or coordinated care on how they are managing your care. And that, again, is the key to risk adjustment. Keep educating yourself on how to get the best optimization in your clinical documentation by incorporating those diagnoses that came from that specialist, right? Bringing those into your note and reviewing it during that face-to-face encounter with your patient, telling them what the expectations are, if there were changes in medications that maybe you need to adjust now. Again, hovering over the situation and making sure everything goes according to plan. Now, in this model of risk adjustment, the CMS model of HCC and the HHS model, key points to remember: those demographics and the documentation of chronic conditions and some acute conditions. Those chronic conditions, people want to, well, give me a definition, Sean. What is a chronic condition? They want me to define a chronic condition. Well, I'm not a clinician. I will say that in my 28 plus years in medical healthcare, as a medical coder or a CDI professional, I've seen that most chronic conditions are going to be those conditions that are lasting more than 90 days, more than 6 months. It is continuing. Your blood pressure was high for 2 months and then you went back, it was normal. That's great. Your blood pressure was high for the last 6 months or maybe the last year. That might be hypertension and it might be chronic. But again, that is something that the physician or the clinician that is attending to your care or managing your care would diagnose. What my expertise is as a clinical documentation integrity specialist is to take that clinical documentation, review it, and then translate that into either ICD-10 codes or CPT codes or HCPC codes. And the HCPC, those are going to be those codes coming directly from CMS that are relative to injectables and things like that. So we'll get into those three coding books that you definitely want to have an updated coding manual in your office, including a current ICD-10 manual. They come out every year in October. Yeah, October 1. So next month, you will get the 2023 ICD-10 books will come out. And then you've got beginning January 1 of every year, you're going to have your updates to the CPT or the current procedural terminology books, as well as your HCPC books. So, time check, how we doing with time? Perfect. We are right there. All right, so we're going to continue on. I'm going to check online and see if there's any questions there. Oh, hey, Jackie. Thank you for joining. Thank y'all for joining me. I'm so happy to see you all on here with me while we walk through this, navigate this difficult, muddy waters of risk adjustment and risk adjustment coding. Now, in this model, again, as I mentioned, it's a predictive model. So in thinking about this predictive model, they're using predictive analytics to estimate the future cost of the patients. So how do they do this? So think about current year. Well, let's back up. Let's talk about 2021. So from January 1 of 2021 all the way through December of 2021, every time your Medicare enrollee appeared in your office, any chronic condition that falls within one of those 79 HCC categories was documented and submitted in a claim. Those diagnoses then were submitted to the health plan through the claim. Claim was approved, and then those then funnel over to Medicare. Medicare gets those diagnosis codes, and when they get those diagnosis codes, they are able to then add those to the demographics. So you've got how they aged into Medicare, how they became eligible, what their income status is, and all of this is adding up to that patient's risk score. And we'll talk about the risk score. And then you have those diagnoses, and that is an additive model. So demographics, interactive diagnosis, and those chronic condition and some acute conditions all add in there and layer in that model. Once those are all layered in, you have the outcome of what's called a risk score. So or a risk adjustment factor, you will also hear that term. So the risk adjustment factor is how CMS allows cost expenditures to the health plans that then funnel back to how they pay the providers. And that is the cost of care that is allotted for your patient. Follow me on this one. I want y'all to lean in. Lean in. Follow me on this one. So with the predictive model and looking at all of the diagnosis in the prior year, every diagnosis that came in last year, including those acute conditions that fall into the model, those impact your overall risk score. So at the beginning of the year, this year, you've had a patient who's been in Medicare or Medicare eligible for the last 2 years, and they've had all their appointments, and now they've got their risk score. So they've got a basic demographic risk score, which on average, depending on whether you're a male or female, also, what also depends within that is whether you live within the community or an institution. So those demographics, not only how were you eligible for Medicare, but are you a male or female? Do you live in the community or do you live in an institution? Meaning, are you living in a nursing home? Are you living in a behavioral health facility? How do you interact in your community, in the community or in a facility? They're also looking again at the diagnosis. Now, what's being added in the last 3 to 5 years, more and more to the model, is social determinants of health. So it isn't actually calculated within the risk score at this time, but let me just put a pin there. What are social determinants of health, Sean? So let me just kind of paint a picture for you. Let's talk about my grandfather. So to give you some light, my grandfather, OB, his nickname was Honey Bunny, really. So we called him Honey Bunny because he had diabetes. And for those of you in the African American community, you know that we call diabetes the sugar. That's right. So that's why we called him Honey Bunny, because he was sweet and he had the sugar. So Honey Bunny had the sugar. This is my grandfather. He's also a widow. So I'm painting the picture for you so that you can try to understand his social determinants. Due to his diabetes and other chronic conditions that he didn't drive anymore. So there was a deficit for him that he no longer had his own transportation to get to and from the grocery store or to and from his doctor's appointments for that matter. So in that sense, there was a social determinant impacting his health because, one, he couldn't always jump in his car and go to a grocery store that had great vegetables, that were fresh vegetables and fresh fruit that he could get to. Sometimes he could only get to the corner store. And then there was also the opportunity for him with transportation. Many of times with his appointments to his doctor's appointments, he would use public transportation, such as Metro Lift or Metro. And now there's rideshare options for Medicare enrollees. But for Honey Bunny, when he was here with us, he just had Med Lift. And with that med lift, from time to time, they pick up those Medicare enrollees. They pick them up 2 to 3 hours early, or sometimes even further than that. And they're sitting and waiting for their appointments, so they're missing opportunities to take their medication on time, also to eat on time. These are things that impact their health, right? Social determinants, right? Not having access to healthy food options, not having transportation to get to and from their healthcare provider when needed or when appropriate. And so these things impact also their living environment. Being homeless is a economical social determinant of health when thinking about that. If you're homeless, it's difficult for you to keep up with your prescriptions and your focus is, where am I going to lay my head tonight? Is it going to rain? Is someone going to steal my things if I leave to go out to the doctor? So this is an impact to their health. And a lot of those people will not seek health because of those opportunities. So when thinking about these social determinants, Medicare and Medicaid are now looking at that, and they're beginning to incorporate this more and more into this risk adjustment model. So my providers are needing to document those things, but oftentimes they're not even aware that it's happening. Some are, but truly at the front desk, they hear it all. They know that Mr. Maloney or Honey Bunny showed up 2 hours early because he rides Metro Lift. And they know that he's probably going to be there 2 hours after his appointment waiting for his ride of Metro Lift. So he's probably missed breakfast and lunch and getting close to dinner. So, do you think that his sugar is going to be, or his hemoglobin A1C is going to be a little off? Probably so. Is that going to be an impact to the outcome of his health? Probably so. And so, in that sense, CMS has started to incorporate that in how they look at the outcomes of healthcare for providers. Um, when thinking about that, we want to make sure that our providers know how to document that. What's important to document? I've got maybe a good 10 minutes to be with the patient, and I'm probably only going to see them once a year. And I've got 10 minutes and I've got to document all of this stuff. How on earth can I get this done? That's why we're here. The experts with MedCenter Revenue Management Solutions can help you get there. That's what we're here to help with. Now, getting back to this model and how it works for providers, again, this is annual reporting for your Medicare enrollees. You need to make sure that you're reporting these diagnoses every year. And I hear often in these communities, just report it once a year. No, report it every time you address it. If you did the work, you should be documenting it. And if you document it, then you should be getting paid for it. So we definitely want to make sure that we're reminding our providers the importance of documenting everything that you've done and making sure that it makes it to the claim appropriately. If you don't have a certified coder in your office, maybe you can look at having one part-time or someone as an oversight coder who can come in and provide oversight to your providers and staff to make sure that they're coding to the highest specificity to ensure that, one, your CDI is tip top. Also, another thing I encourage my providers is to remember that continuity of care. When they're referring their patients out to that substitute teacher we talked about earlier, make sure that you're getting that report card back, right? That report card or that consult note, which is going to validate, one, what they're treating and managing, which is no longer going to be something that you need to treat or manage, right? Instead, you're going to make sure that your patient, your Medicare enrollee, is going to that appointment and that they're taking the medications and or therapies that were prescribed and that it's working for them. And if it's not, then you would be that conduit to help them adjust that. Make sure that they're referred to the appropriate specialty for the best outcome. And again, remembering to educate yourself. That is the key to risk adjustment. You should educate yourself on what you need to know. Why do I need to document this every time? And what truly needs to be in the chart? And, in this podcast, we're going to dig deep into that. Each podcast will have a little bit more of what you need to know. We will also have those specials where I will have physicians who are working in the industry right now who can share with you their pearls to success, what they're doing to make their risk adjustment process work in their office. Now, online, we're getting some guests, and I'm so grateful to see people popping in and popping out. So thank y'all so much. Thank you. Yeah, I'm glad to know this is good information. I'm happy to share it with you. Please share a friend, tag me, share a friend, have them on the call. We'll be here next Thursday, same time. So, one of the things in risk adjustment, now we tell our providers to make sure you document. One of my famous sayings, one you've already learned, and you'll hear it throughout every podcast at least. This is a Kodak moment. You'll also hear me say, documentation rules the nation. Listen, if I say it once, I'll say it a million times. Documentation rules the nation. If it wasn't documented, CMS tends to feel, or health plans tend to feel, it didn't happen. We know full well that it happened. My provider was in there with that patient for 30 minutes, maybe an hour, and they went through every medication. They answered every question. They wrote prescriptions. They also wrote labs. They also wrote if you will, referrals to specialists. And so in that, I want to make sure that everything my provider did was documented well so that we can get them the the most optimization in revenue reimbursement. And that's what the key to this is. So CMS takes those diagnoses over the year, and then at the beginning of the year, they say, okay, we've got this patient, they've got chronic kidney disease, they're also diabetic. So is that diabetes relative to the chronic kidney disease? Because we got a claim from the PCP that says they have diabetes without complications. Then we got a claim from the specialist, right? And that radiologist noted that they have stage 3 chronic kidney disease. So, is it diabetic chronic kidney disease, or does the kidney disease not have any etiology or manifestation from the diabetes? That oftentimes is the difference in whether there is an optimization of revenue reimbursement for that patient, or I say revenue reimbursement, or revenue allotment for that patient versus not. So picture this. Think about this. Predictive model. Patient has these chronic conditions, but the doctor didn't document them all. A lot of them didn't make it to the claim. So now we're at the beginning of the year. CMS has looked at all of the conditions from the prior year, and they're saying, okay, from the demographics and the interactive diagnosis and the ICD-10 codes, we've determined that this patient has a risk score of blah. So as a point of reference, CMS sees that a patient with a risk score of 1.0 is an average patient. They may have a few chronic conditions. They may have none. They may have one. They tend to see that as an average patient. Patients who have a risk factor or a risk score greater than 1 tend to see those patients, or they tend to be deemed as having more chronic conditions and or maybe require more management in their care. They might be deemed as more ill because they have more chronic conditions that are being managed. As again, in this model, it's an additive model, right? Those HCC categories are adding. So I've got diabetes, and I've got hypertensive heart disease, and I've got chronic kidney disease. And on top of that, I've got a little dementia, and add that in there. And on top of that, there's also some behavioral health, add a little bipolar into there. And again, each one of those falling into a different HCC category is ratcheting up that overall risk score for that patient. Now, how do we get to the revenue of that? So you've got these diagnoses, you've got your demographics, you've got your interactives. And so we've got this risk score. So we talked about a baseline of 1, right? 1.0 is an average risk score. Less than 1 is going to say that this is a fairly healthy patient. They don't have any chronic conditions or any acute conditions that have caused them an overnight stay in a hospital or that need to be managed outside of the inpatient setting. And so when there is a risk score that's lower, those are tend to be seen as a more healthier patient, or a patient that doesn't require as much medical management. Now, if we've got a patient who truly has these chronic conditions, they've got all those conditions I named, they could have a risk score. Let's just, pull one out of the air of, let's say, 2.5. So CMS has in each region how they reimburse those regions based on that capitation rate for risk adjustment. Now, capitation, if you're not familiar with it, that is how this risk model pays, which is different for providers. So I'm going to switch gears here because I want to make sure that I bring this in appropriately before we go forward. Most of us go to the doctor, right? And our doctor comes in, you say, I'm coming because I have an upset stomach and I've been having a headache. So they say, okay. And they've got protocols in the office when you come in. You come in, they may run a couple of labs, they may do a couple of field tests, and they come up with a diagnosis. They've had a physical exam with you. There was some medical decision making that took place within there. And from that, they were able to come up with a diagnosis. And with that diagnosis, there was the procedures that were done in order to determine that diagnosis. So there was the physical exam, there were the tests. They also reviewed a few radiology slides, so some x-rays. And from that, they were able to determine that you have pneumonia. So now you've got your diagnosis and you've got the procedures of what you've done. And in that case, with all those things the provider did, that may be a level 3 or 4 of their evaluation and management. So you've got that diagnosis and you've got the procedure code, and those things go out on a bill or a claim to the health plan. So once they get out there to the health plan reviews those and they look at all those diagnoses, and then those that fall into HCC categories get forwarded on to CMS and get attributed to your Medicare enrollees risk score. Now, if the provider didn't document those to the highest specificity, in other words, instead of saying that the patient had diabetes with chronic kidney disease, they just said they have diabetes and they also have chronic kidney disease. So they didn't combine those two codes together. That could have been if, in fact, the chronic kidney disease was a manifestation of the diabetes. There is a different risk adjustment weighting for that. So CMS looks at that and they're saying, okay, we didn't get those diagnoses reported, so it's just as if they didn't happen. They didn't come across in a claim. They may request your medical records, the health plan may, so that they can come back and try to find those diagnoses to submit those. But that is how that risk score gets calculated. CMS then takes that risk score and they take those regional fees that have been broken out, right? They've taken what fee for service happens and they create what's called a capitated rate. It is a per member per month rate, a flat rate that the provider is paid to care for those Medicare patients. Versus when we go to the doctor and they run those tests and those labs and they submit to the insurance company a commercial plan, they're getting paid fee for service. They provided a service in which there is a fee schedule for with every insurance company they're contracted with, and they will be reimbursed at that contracted rate. That is fee for service. The exact same visit with the exact same diagnosis for a capitated provider, however, if their capitated rate, their per member per month rate is $50, then they will be paid $50, even though in a fee-for-service world, they may have been able to bill $350 for the services that were provided on that encounter. But in a capitated environment, they're getting paid that $50 per member per month. Now, the caveat there, because some of us online are going, what? Wait a minute. How does that even make sense? Right? Why would a provider do that? Well, think about this. They're getting paid that $50 whether they see the member or not. So if your member never comes to your office, you're still getting that $50 per member per month versus seeing 30 patients in order to make the money that you would make. Now, model isn't for everyone. Doesn't work for every provider. Most providers have a mix of fee-for-service patients and capitated patients. But I will tell you that it is a very successful model for some providers who understand how to work the model and have the staff. It truly is not something that a single provider can do on their own and be successful. Certainly there are providers out there that are kicking butt, doing a very good job with them and one person in their office. But it is difficult. And again, that is why MedCenter Revenue Management Solutions is here for you. We can help you with all of your risk adjustment needs. Certainly, making sure that you're getting the optimization of your revenue as it relates to your CDI processes. Now, again, with that yearly reporting and that breakdown, that difference between fee for service, right? Provider going in or patient going in, having a service provided, and within that service, the provider being paid a fee versus in this model, providers are getting a flat rate capitated per member per month. But think about this again, the more members they have in that capitated plan, the more they get. So if they've got 1,000 members and they're getting paid $50 a month per member, right? $50 times 1,000, you do the math, and then multiply that by 12. And that's what they're getting, whether those patients come in or not. Now, they could come in once a week. They could come in twice a week, and they would still get that same rate. But it's not likely that every patient in a provider's caseload is going to require that much medical management. Now, I'm getting closer to my wrap-up time, and I wanted to make sure that I pointed out a couple of other key points about risk adjustment before we wrapped up, and I wanted to answer any question to my online people. So one thing I wanted to remind in the risk adjustment model, this is very, very important to remember that documentation rules the nation. Make sure that you document it and that you documented it clear. Make sure that you're showing cause and effect. Make sure that you're showing in your documentation those disease etiology and manifestations. Clearly link complications and manifestations of a disease process. If they've got hypertension and now they've developed or it's advanced to hypertensive heart disease, code it as such. If you don't know the code, call me. I know it. Also, don't hesitate to look at quick reference guides and to log on to podcasts like this. There are other podcasts out there that can also help you with your coding in risk adjustment. Remember, don't only document the history of. Oftentimes, our providers live on their problem list, which is great if you have an up-to-date and current problem list, meaning that that problem list has current conditions that are still being managed and those conditions that have resolved have been removed. And any pertinent surgeries that could impact them, any social issues, that they're a current smoker or that they have Alzheimer's and they live alone or that they live in a facility. Those things being documented can, one, help you document your social determinants, as well as help you making sure you have a clear picture that you're painting to CMS about how you are managing the care of your patients. So in risk adjustment, think about kindergarten. Think about the first time you saw that box of crayons that had 64 crayons. And you could use any crayon you wanted to color your picture. Here's your opportunity as that CDI professional I know is in you. Every provider has it in them. Use every color to paint that picture. Even that cyan, the one that no one ever knows what to color with. But use that to paint the picture about the conditions that your patients have. Document it, code it, put it in a claim, make sure the claim goes through, and then make sure if your records are requested for validation, feel confident that you document it to the highest specificity and that your records are compliant, and send it over. And if you are not sure, make sure you reach out to me. We can certainly help you with that. And if not, MedCenter Revenue Management Solutions, there are a host of other CDI professionals that are very well experienced that can really help you in this site. I want to give some special acknowledgments to a couple of people who helped me get this podcast up. With my last 2 minutes, I want to give recognitions. One, I want to say a big shout out to Car Crash Clinic of Houston, Mr. William Shepard. Thank you, William. I want to send a big shout out to Taylors of Houston, Mr. Vaughn Taylor and the Taylor family. I also want to send a big shout out to Melissa Peak, who is one of the boss ladies of the PI community. And lastly, I want to send a big shout out to my husband, my support, my best friend, and my children. My daughter, who's my boss, who makes me be here. Thank you. And to my adult children and grandchildren, Nana will be home soon. Thank you all for tuning in. Please make sure that you tell a friend and that you join the Key to Risk Adjustment, because the key truly is keep educating yourself. I'll see you next week right here. See you next week with the Key to Risk Adjustment. Thank you, ladies and gentlemen. Have a wonderful evening.